Hello, good afternoon, everyone. My name is Dr. Mounika. I'm the consultant pediatric nephrologist, team Kim's Cuddles. Today, we are going to talk about renal replacement therapy, which we follow in neonates, and any recent advances which we have seen in the last recent years. So first, basically, before going into the renal replacement therapy, we have to understand how the newborn kidneys are different from the pediatric kidneys. So coming to the renal blood flow, there is a very high resistance in the fetal period, because of which there is effective ultrafiltrate pressure is very, very low, and ultrafiltrate coefficient is also very, very low. So during the fetal period, the blood flow to the kidney is only 2 to 3% of the cardiac output. Post-delivery, in a term child, the renal blood flow increases to 15 to 18% of the cardiac output, whereas in adults, it accounts for around 20 to 25%. So coming to the glomerular filtration, usually it starts in the antenatal period by 9 to 12 weeks. So the GFR, because there is a decreased effective ultrafiltration pressure, the GFR at birth is presumably very low. That is around 15 to 20 ml per minute per 1.73 meters square. So it usually doubles by second week and become 3 times by the end of 8 weeks. That will around 75 to 80 ml per minute. And by 2 years, it reaches the adult level. So because of the increasing blood flow post-delivery, there is also an increased blood supply to the outer cortex, increasing in the number of effective nephrons. The serum creatinine is highest at the birth. That is because it reflects the maternal circulation. But there is also a premature tubules which are there in the child, because of which there is always reabsorption of the creatinine, because of which this creatinine usually peaks during the first week, then normalizes by around 3rd to 7th day in a term baby, and by end of 2nd week in a preterm baby. Coming to the urine output, the factors which determine the urine output are the solute load and the renal concentration ability. So the solute load, because there is ineffective filtration, because there is high resistance and a decreased blood flow, the solute clearance is low during birth, and the solute clearance is high. The solute load is high in the body, and the renal concentrating ability is low. Thus, the urine output is presumably low during the newborn period. So we can name the child oliguric only when the child produces less than 1 ml per kg per hour. Instead of in pediatric age group, we term oliguria as less than 0.5 cc per kg per hour. Coming to the urine concentrating capacity, it is very limited. So that is because there is a shorter loop of Henle. The medullary tonicity gradient is also low, and there is a decreased responsiveness towards the ADH. So because of these factors, the urine concentrating capacity is low. Normally, we see the urine osmolality to be around 900 to 1200. But in preterm babies, it is only around 500 milliosmoles, and in term babies, it is 800 milliosmoles. Urine diluting capacity, that is the ability to excrete water load, is very poor in the preterm. So that is why excessive water content is not given to the preterm babies, because they cause hyponatremic. They cause dilutional hyponatremia. That is one of the reasons. Coming to the tubular pathology, the FENA, that is fractional excretion of sodium. This means how much the tubules are able to reabsorb the filtered sodium. Lower the FENA, better is our tubular activity. In the fetal period, the FENA is around 20%. That is very, very high because of the immature tubular system. In a term child, it is almost similar to the adults, that is less than 1%. But in preterm child, the excretion, the sodium reabsorption is very less, and FENA is around 5%. That is why we see that in preterm breast milk we have higher sodium content than of the term babies. So around the term babies, the breast milk sodium is around 7 millimoles, but in preterm babies we see up to 25 milliosmoles. And coming to potassium, sodium and potassium both are very, very important for a somatic growth. And the term babies or a preterm babies, they always tend to have a positive potassium balance. In very low birth babies, we almost see potassium as more than 6.5% in many cases. The bicarb threshold. So what is in newborns, there is a low renal threshold. That means that post 21 milliosmoles, the body tends to excrete the bicarbonate, and in preterm, the threshold is lower up to 18 millimoles. Sometimes this physiological lower bicarbonate can be misdiagnosed as a renal tubular acidosis. Neonatal acute kidney injury. Neonatal acute kidney injury is nothing but abrupt decrease in the functional status of the kidney, leading to impairment in fluid and electrolyte disturbances, and clearance of the and retention of the toxic substances. So, in 2014, the KDIGO, that is kidney disease in so the KDIGO has started and have comprised many guidelines, and then derived at a modified KDIGO guidelines for neonates, which is specifically designed for neonates because of their depending on their urine output and the kidney status in children, in newborns. So if there is no AKI, so there is no change in serum creatinine, and urine output is more than 1 ml per kg per hour. In stage 1 of AKI, there is a raise of serum creatinine of more than 0.3 mg per dl within the first 48 hours from the baseline, or there is 1.5 to 1.9 times raise from the lowest value within the 7 days. And the urine output is less than 1 ml per kg per minute, but more than 0.5 cc per kg. Coming to stage 2, the serum creatinine raise is 2 to 2.9 times from the baseline. That baseline means the lowest value we see within the last 7 days. And there is a even more further decrease in the urine output, that is less than 0.5 cc per kg, but more than 0.3 cc per kg. Coming to the stage 3 of acute kidney injury in neonates, there is a raise of creatinine more than 2.5 mg per dl, or more than 3-fold raise from the baseline, or we have already initiated kidney replacement, kidney support therapy, that is kidney replacement therapy, and the urine output is less than 0.3 cc per kg per hour, then we call it as a stage 3 kidney injury. So what are the causes? I will just briefly tell you. So most of the times, the insult to the newborn kidney can happen anytime between from the antenatal period, perinatal period, and the postnatal period, because of which the AKI can occur. And this we classify in 2 categories. One is whether, depending on the cause, we classify as a pre-renal, intrinsic, and a post-renal AKI. Depending on the urine output, we classify them as oliguric and non-oliguric AKI. So the most common cause is the pre-renal AKI. That is the risk. The children with so the pre-renal AKI is caused because of volume contraction, like decreased placental perfusion or increased losses, insensible water losses. Or if there is any hemorrhage, that is twin-to-twin transfusion, feto-maternal hemorrhage in such cases, and hypoxic injury, sepsis, cardiac conditions like complex cardiac diseases, and polycythemia. Coming to the intrinsic AKI, here the injury has already occurred, which is leading to the failure, like in acute tubular necrosis, which occurs due to drugs, hypoxia, or hypoperfusion injury. So the pre-renal AKI can be converted into intrinsic AKI if we do not intervene in the pre-renal period. And the drugs like vancomycin, aminoglycosides, AC inhibitors also cause intrinsic AKI. vascular malformations like renal vein thrombosis, renal artery thrombosis. They also cause intrinsic AKI. Cystic kidney disease like multicystic dysplastic kidney or a polycystic kidney like ARPKD can also cause intrinsic AKI. Coming to the postnatal AKI, so congenital anomaly, CACUT is congenital anomaly of kidney and urinary tract. So the structural abnormality. So here there is a injury. There is always failure because of the structural abnormality, because of which it is causing injury. It is the other way around of the intrinsic. So first the injury occurs because of the underlying cause. Obstructive uropathy, fungal balls, urate nephropathy, they all cause postnatal AKI. So the management of AKI, as we all know, I will not be talking about that. I will be talking more about the peritoneal dialysis, CRRT and IHD, which we can perform, the renal replacement therapies. So what is dialysis? Dialysis is solute clearance across the semi-permeable membranes. So in peritoneal dialysis, the peritoneal membrane itself acts as the semi-permeable membrane. So the basic principles for peritoneal dialysis are diffusion, osmosis, and ultrafiltration. Diffusion is there is solute clearance from high gradient to low gradient. That is diffusion. Like example, there is high urea in the blood. So the first compartment could be the blood where there is high urea. Where from higher concentration to lower concentration, that is the peritoneal cavity. Where there is no, in the PD fluid, we don't have any urea. So here there is low concentration. So because of diffusion, the urea gets cleared. That is diffusion. Coming to osmosis, that is clearance of water from high gradient to low gradient. So when we are in fluid overload state, the newborn is in fluid overload state, the intravascular compartment has more fluid, which is getting shifted to the intraperitoneal cavity because of osmosis. That is from higher gradient to lower gradient. What is ultrafiltration? So ultrafiltration is also a modality which is helpful for clearance of water, that is the fluid. So this is because of the oncotic pressure in the capillary system. The ultrafiltration happens because of the pressure. The water is pushed into the peritoneal cavity. So what are the basic indications for for instating or reinstating the peritoneal dialysis? Uremia. There is a refractory hyperkalemia. Even with medical management, the potassium levels are increasing. Refractory metabolic acidosis, excess fluid and fluid overload. In some cases, even though the urine output is good and the child is minimally in a positive state, we want to make provision for the extra fluids or the blood products, which we want to give in a oliguric AKI. In such cases, in oliguric AKI, in such cases also, we can prefer peritoneal dialysis. So as we all know, we know how to insert a peritoneal catheter, and this is how the system looks. So there is the peritoneal dialysate fluid bag on one end, through which we have a measuring device which has the measurement of how much ml we can calculate and we can let it in. We have a three-way cock. This end is connected to the peritoneal catheter. We usually put it infraumbilical area, and we put it in the iliac space for the dependency. And so once there is in, we let the fluid in, and we close the three-way tap. We let the fluid rest in the abdominal cavity. Then we again turn the three-way tap so that the fluid can be drained into the out bag, and there is regularly measured. So coming to the PD prescription, so we have different types of peritoneal dialysis fluid. So the first, when we write a prescription, these are the headings under which we have to mention so that we don't miss on any, we don't miss it on any of the important parameters. So first we want to know is the type and the concentration of the dialysis fluid. So it can be the commercially available bags are 1.7 to 1.7% dextrose dextrose containing peritoneal dialysis fluids are available. We have to manually make it into 2.5% dextrose. This is for acute peritoneal dialysis. In cases of CKD, where we go for a CAPD, where there is a continuous peritoneal dialysis, they have different bags of 1.5 to 2.5 concentration dextrose. But for acute PD, the commercially available bags are 1.7% dextrose. It can be lactate based, which is commercially available, but depending on case to case, the clinical condition of the child and the underlying etiology, we have to choose either if we want a bicarbonate based peritoneal fluid, which has to be prepared manually, which I will be talking about little later. So that is a type of fluid. Next will be, what will be the fill volume? So in infants, we start with 10 to 20 ml per kg of the fill volume. This we can increase up to 20 to 30 ml, but we have to make sure that we are not decreasing, affecting the tidal volume of the lung, or the child is not having any tachypnea, or child is going into a cardiac failure. Ensuring these three, we can increase the fluid volume to 20 to 30 ml per kg. That too depending on case to case. Suppose if we have having a good clearance with 10 to 20 ml per kg, we can continue the same prescription. And in time, so in 5 to 10 minutes, we have to let the fluid into the abdomen, and that is called as the in time. So one thing which we have to make sure is we have to never let a cold dialysate fluid go into the abdomen, because it causes a lot of pain. So in newborns, they may not express as the pain, but there will be excessive crying and irritability, because of which our peritoneal dialysis will be hampered. So we have to warm, not hot, but warm the peritoneal fluid, and then only we have to make it enter into the abdomen. So our next parameter is the length, that is the dwell time. So dwell time, we usually start with 15 to 20 minutes and then increase to 20 to 30 minutes, depending on our clearance of the solute, our aim of the PD. Like we want more clearance, we want more fluid. So if you want more clearance, we prefer a longer dwell time. If you want fluid removal, rapid fluid removal, we go for a shorter dwell times. And out time is 10 to 20 minutes. So we say 5 to 10 minutes we start with. If we have a positive balance, then we go for a longer out time of 10 to 20 minutes. And next will be the number of cycles. So we are anticipating this child has fluid overload. So how many cycles we are anticipating to do, that is what we are noting down. And duration of the each cycle. So one cycle consists of the in time, dwell time, and the out time. So together we say the duration of each cycle. So total treatment time. So we have started to, when we start a PD, we usually run for up to 72 hours. Or in between the child has responded, we will not remove the catheter, but we will clamp it and keep it, and we will see the improvement in the parameters, or we can sometimes restart it. So what are the additives to the dialysis solution? Like we add 500 units of heparin in 1 liter of bottle. And potassium, initially we start as a potassium-free dialysate fluid, because the commercially available dialysate fluid does not contain potassium. So we continue potassium-free for few cycles. After that, when we see our serum potassium levels are borderline low, then we start adding 2 to 4 MEQ per liter after few cycles. That is to maintain the serum levels. And so there is, with the peritoneal dialysis also, there is always a chance that that drug clearance is there. So in these children, we have to make sure that renal drug correction has happened, and we give additional doses in case we see that there is an excessive clearance during peritoneal dialysis. So what are the modifications which we do? As I have told earlier, so in pulmonary edema, we want is clearance of the fluid. So we go for a shorter dwell time. And the dialysate fluid concentration also we increase to 2.5%, because of which the osmotic gradient is occurred, because of which there is a faster fluid clearance. So in pulmonary edema, we go for shorter dwells and a higher concentrated dialysate fluid. In a child with hypoxic history, in hypoxic insult, the child will be unable to metabolize the lactate. So in such cases, we have to go for a bicarbonate containing peritoneal dialysis fluid. In severe metabolic acidosis also, we go for bicarbonate PD that can be done with shorter dwell time. So when you want to correct the metabolic acidosis also, we go for a shorter dwell time. So how do we prepare the bicarbonate based PD fluid? So we have to take solution A, that is 440 ml of 5% dextrose. To that we add 60 ml of sodium bicarbonate. That is a total of 500 ml. Of this, we are taking 250 ml and adding it to the bottle. And we add 500 ml of NS. So together, it forms a 750 ml of bicarbonate-based PD fluid, which has 140 milliequivalents of sodium, 40 milliequivalents of bicarbonate, and 1.5 grams of dextrose. So sometimes they ask me, Madam, can we add the bicarbonate directly into the PD bags, which we are getting commercially? So the peritoneal dialysis fluid contains calcium. So you can't add bicarbonate into that because there is a risk of crystallization. So we should never do that. We have to manually prepare the bicarbonate-based fluid. Coming to the monitoring, so when the child is ongoing peritoneal dialysis, we regularly monitor pulse, blood pressure, along with the accurate intake and weighing of the child. So all this put together, we will know. So suppose if there is an error which has happened in the PD charts, so the weight records will tell us like, okay, the child is having, because there must be some fluid in the abdomen, the child weight has drastically increased. That could give us a clue. So that is why weight records, pulse, blood pressure, these are all very much important. And most importantly is the color of the peritoneal fluid. So most of the times we see is that when the newborn period, when we are doing peritoneal dialysis, I say in my experience around 60% of the time the child is ventilated. Correct. So pain, irritability and all are not seen because the child is already ventilated and sedated. So color of the peritoneal fluid, fibrin threads in the peritoneal fluid is one thing which we have to importantly make note. Electrolytes and sugars should be monitored every 12 hourly. So in peritoneal dialysis, because of the dextrose in the peritoneal fluid, the dialysate fluid, sometimes hyperglycemia may also occur. In such cases, we add regular insulin directly into the peritoneal dialysis instead of adding from the external source. So in this way also we can do the modifications. So the blood urea and creatinine can be done once in a day, and peritoneal fluid dialysis should be sent when we are suspecting any new onset sepsis, or there is any color change, or there is cloudy peritoneal dialysis. In such cases, we send the peritoneal dialysis for analysis. So the relative contraindications are systemic hypotension, necrotizing enterocolitis, bleeding diastasis, or a ventriculoperitoneal shunt. Sometimes some structural malformation like exstrophy of the bladder. In such cases also, and umbilical hernia also are the relative contraindications. Surprisingly, in sepsis, the peritoneum is the blood flow to the peritoneum is increased. So we have a better clearance. So that sepsis we can take it to our advantage when we are doing peritoneal dialysis. So coming to the continuous renal replacement therapy, that is the CRRT. So basically, when we talk about the renal replacement therapy, other than peritoneal dialysis, we have the mechanism is same. That is, along the semi-permeable membrane, there is a solute and water clearance, correct? So in peritoneal dialysis, our peritoneal membrane is acting as a semi-permeable membrane. Here, the dialyzers itself act as a semi-permeable membranes. So here, depending on the duration, our CRRT, our replacement therapies are divided under broad headings as intermittent hemodialysis, that is for a shorter duration, which we do for children with CKD. Isolated ultrafiltration, that we do for, that is just we are removing the fluid, but we don't want the solute clearance. We just want fluid overload to be corrected. That is isolated ultrafiltration. In hybrid therapy, that is SLED or SLED plus F, that is sustained low efficiency daily dialysis. The duration is little longer. Intermittent, usually we prefer 4 to 6 hours. In hybrid, when we come to the SLED, we go for 8 to 10 hours. That is called as SLED. So here, the efficiency, when you take the efficiency of solute clearance is highest in IHD and lowest in CRRT. But that we don't want the rapid correction because the children are hemodynamically unstable when we are preferring CRRT, correct? So in hybrid model is a mix of both. It has intermittent clearance, intermittent solute clearance, and ultrafiltration can be used in any modality. And coming to the continuous, that is, we are continuing. Once we start CRRT, it is always more than 24 hours, depending on our clinical condition of the child. So in this, we have CVVH, CVVHD, CVVHDF, and SCUF. So CVVH is continuous veno-venous hemofiltration. Okay. CVVHD is continuous veno-venous hemodialysis. That is hemofiltration. This is hemodialysis. I will talk about these modalities in the next coming slides. Coming to CVVHDF, it is continuous veno-venous hemodiafiltration. That is, we are using both the modalities of CVV H and CVV HD. We are using. SCUF is slow continuous ultrafiltration. So ISO-UF with and SCUF is the same, except the duration. So coming to the principles of CRRT, we have diffusion, convective clearance, and ultrafiltration. So in diffusion, there is, so here what we are seeing in the first image in the left top corner is the dialyzer. So there is movement of the solutes across their concentration. That is, in the blood, the concentration is higher, like in urea and creatinine, than the dialysate fluid. So because of the diffusion method, we have the smaller solutes which are getting cleared from the blood to the dialysate compartment. This is called as diffusion. Coming to ultrafiltration. So in CVV HD, we use diffusion. HD. Coming to ultrafiltration, that is the right top corner image. So we have blood, we have ultrafiltrate. So because of the pressure gradient, there is a shift of fluid, only fluid, from the blood to the ultrafiltrate compartment. That is ultrafiltration, which we are using in ISO-UF or SCUF. Okay. So coming to the left lower image, here is convection. So what is convection? Here, there is ultrafiltration which is happening, as we know. Along with ultrafiltration, some middle molecules like cytokines and inflammatory markers get attached to the fluid and then are dragged. It is called as a solvent drag. So this middle molecules are dragged along with the fluid into the ultrafiltrated to the effluent to outside, and there is a clearance of middle molecules like cytokines or inflammatory markers. And there is absorption also. Here, the few molecules get adhered to the filter surface itself. These are very, very large weight molecules. So when do we start CRRT? We start it in a sick hypotensive infant, a congestive cardiac failure with fluid overload. In such cases also, we start CRRT. Multi-organ dysfunction, hyperammonemias in infants secondary to IEMs, severe sepsis. These are the routine indications which we use in all our centers. So this we have already spoken earlier. There is CUF, CVVH, CVVHD, and CVVHDF. So these are the first one is CUF. So the red line, the red line is going into the dialyzer. That is the blood going into the dialyzer. Because of the pressure, because of the gradient of pressure, there is a clearance. The yellow line tells us that there is only removal of fluid, and the blue line shows us the blood is returning back into the patient. That is CUF. Coming to CVVH, here we use convection. That is, along with the fluid, there is also a solute drag. Okay. So here we have a pink line which is going into the dialyzer. Here we have a replacement fluid, that is pre and post pump dilution, which is happening. So here we are adding a replacement fluid into the pre pump so that the solute drag and the pressures which is exerted for the clearance is increased. And then because of which in the effluent, in the out effluent, we can see that there are particles along with the ultrafiltrate which has come out, and there is the other access line which is going out, going into the patient, and we also add a post pump to maintain the hemodynamics. So coming to CVVHD, here the principle is diffusion. Diffusion is gradient. Along the gradient, concentration gradient, the solute is getting cleared like urea and creatinine. So there is an access line which is flowing from top to bottom, and the dialysate fluid which is getting attached to the bottom, which flows in the opposite direction, because of which there is a concentration gradient maintained all along the dialyzer, and there is clearance of fluid and the solute into the effluent. So coming to CVVHDF, these use principles of both CVVH and CVVHD. So here we have replacement fluid along with the dialysate fluid. So we say that the best modality for the best clearance is CVVHDF. So in India, presently, we are using Baxter Prismaflex machine. This is the machine, and we are using Fresenius 508 machine. The infants or the newborn babies, The least we can start on is around 3 kgs on a Baxter Prismaflex machine with the filter of HF20. But 5008 is usually used for older children, more than 10 kgs. And coming to the latest innovations which we are seeing, coming to the latest innovation. So in the UK and the US, in Europe, now they have designed for a newborn, for the newborn states, we are using this new machines called as CRRT, that is Cardio-Renal Pediatric Dialysis Emergency Machine, CRRT, and NIDAS, Newcastle Infant Dialysis Ultrafiltration System. So here, what are the advantages? So this CRRT is for usually very, very small infants. So normally the HF20 filter, which we use in India, the surface area is around 0.4. But in CRRT, which we can use for surface area of 0.07, 0.15 and 0.25 meter square also. So very small infants, very low birth weight, preterm infants also, we can use this machine. Here the blood flow rate can be as minimal as 15 to 25 ml, which is not achieved with the Baxter Prismaflex. And the priming volume is how much the ml of blood is circulated in the whole system. The circuit system is called as priming volume. That is only 27 ml. So that is very, very less. That is the very advantage in using CRRT in a very sick and a low birth weight infants without causing any hemodynamic disturbances. So NIDAS is the Newcastle Infant Dialysis Ultrafiltration System. It's called NIDAS. So this uses syringe pumps. So here we have bags in CRRT, like in Prismaflex, but in NIDAS we have the syringe pump system, and the circuit volume is even minimal of up to only 4.3 ml. That is surprisingly very good for establishing clearance in a very small infant, very low birth weight infant of less than 1 kg also. So what do we require? So in newborns, we use the regular 7 French catheter, and the optimal site is the femoral. But in few studies, we have seen that in newborn children of around 4 days old, they have sometimes used this 7 French HD catheter even in the umbilical vein. Okay. So coming to the anticoagulant, when you use intermittent hemodialysis, IHD, you can sometimes try to do it without any anticoagulant. But to keep the system running, we have to have an anticoagulant in CRRT, that is heparin or citrate. Heparin is which we commonly use. But in liver failure, we go for citrate, where it can be compensated outside. So these are the 2 anticoagulants which we are there. Coming to the filter, we have HF20. The priming volume for HF20 is just 60 ml. One more advantage which I want to tell is we have other filters such as M60, M100 and M150. These are used for older children. The M60 minimal weight is around 5 kg, around 7 kgs. Okay. So these M60, M100, M150, they are all lined with acrolein nitrate. The fibers, the tubes, the halo tubes in the filter are made up with acrylone nitrate. So you can't prime these systems with blood, because as soon as the AN69, this is called as AN69 filters. So as soon as you prime the system with blood, there is a lot of bradykinin release, and which will cause hypotension in the infants. Already sicker infant, and it worsens. So the HF20 is made with polyacyl ether sulfone fibers. So the advantage with this is you can prime the system with blood in newborn children. So that is why there is no bradykinin release when we are using HF20 filters. So coming to the replacement fluid, we have bicarbonate-based replacement fluid, that is Prismosol, Bifazole, and lactate-based are also available. So these are the bags. And so the circuit is actually preformed. Like you have the circuit with the tubings, everything attached. You have to just take the system, attach it to the machine, and the machine automatically takes, and it will tell us where exactly to fix each tube, which is very, very easy. So this we have already seen. So this is cuff, that is pressure driven fluid clearance. Coming to CVVH, that is the convection, that is along with ultrafiltration, there is a solvent drag and there is a clearance of middle molecules, that is a solvent drag. And coming to CVVHD, here we use diffusion. That is, there is a from a higher gradient to lower gradient, there is a clearance along the semi-permeable membrane. CVVHDF uses all the three. That is CVVH plus diffusion and convective clearance. So this we have already spoken about. This is how the system looks like. So CVVH is, we have the inline, then we have a pre-pump. Excuse me. We have a pre-pump, we have an ultrafiltration pump. And because of the ultrafiltration, along with the ultrafiltration, there is also a solvent drag. And then there is an exit line into the patient. In CVVHDF, we have a dialysate fluid here. Here we don't have a dialysate fluid. Here we have a pre-pump and a post-pump replacement fluid. In CVVHD, we don't have it. But in CVVHDF, we have both the dialysate bags and replacement fluids. So the commonly seen complications while performing CRRT are the line-related sepsis. There could be air embolism, the platelet consumption, there is blood loss, electrolyte imbalance, hypothermia, and effects of anticoagulation because of the anticoagulation which we use. So coming to the prescription for CRRT, so in newborn infants who are around 3 kgs, we use HF20 filter. The modality which we have to choose, that is CVVH, CVVHD, CVVHDF, or SCUF. The effluent volume is usually 2000 to 3000 ml per 1.73 meter square. So you calculate our child's body surface area and you calculate the fluid according to our child's body surface area. Of the calculated effluent volume, we divide it into 2:1 ratio. 2/3 the volume is a replacement fluid, 1/3 the volume is for dialysate fluid. So the 2/3 volume for dialysate fluid is then again converted into 85%. We use it as pre-pump. In this modality, this is for CVVHDF. I'm telling you the prescription for CVVHDF. Okay. So pre-pump is usually 85% because this helps in the longevity of the filter, and it will help prevent clotting in the filter because it's quite an expensive and cumbersome procedure. We want the filter to last for a longer duration. And post-pump we usually generally see is 15 ml, 15%. The blood flow rate usually starts at 3 to 5 ml per kg. The minimum blood flow to prevent clotting is 50 ml per minute. But in the Baxter Prismaflex machine, we can set it up to 20 to 25 ml. That is a minimum we can set it. Coming to ultrafiltration, because of the hemodynamic instability, we target ultrafiltration starting from 0.5 cc per kg. We can go up to 2 cc per kg depending on our clinical response. So anticoagulant, we choose whether it is heparin or citrate. Then we do monitoring. And the most important thing is drug dose adjustment. So because the filter is a low flux filter, there can be some clearance of the drugs which have to be supplemented. So I will just tell you an example briefly. So we have a 10 days old neonate who is weighing around 3 kgs, presented with sepsis, with acute kidney injury, oliguria, and fluid overload. Investigation showed elevated urea, creatinine, but with a normal coagulation profile, requiring multiple inotrope support and ventilation. So in this child, if you want to write a prescription, we have chosen, as we have discussed, we have chosen HF20 Baxter CRRT machine. The modality we chose here is CVVHDF because there is some fluid overload and also acute renal injury with multi-organ dysfunction. So the child is a 3 kgs child. But the minimal flow on the machine is 25 ml per minute. So we start with that. Because the child is around 3 kgs, the body surface area is around 0.2. So the effluent volume comes around 500 ml, total effluent volume. This we divide 2:1 ratio. So 332 ml of replacement fluid and 135 ml of the dialysate fluid, of which pre-dilution is 85%. And the post-dilution, I'm sorry, the numbers here are a little wrong. So of this, we take 85% of pre-dilution and 15% post-dilution. And the dialysate fluid is around 1/3 of the effluent volume. Because the coagulation profile is normal, we start with heparin of 10 cc per kg per hour. that is 300 units per hour. And ultrafiltration, we started with around 0.5 cc per kg to 2 we can start. So we have chosen 5 ml per hour in this child. So coming to the in newborns, how can we see? So when we start the peritoneal dialysis, we usually continue it for 24 to 72 hours. While as intermittent hemodialysis, we use it for 4 to 6 hours, and CRRT is more than 24 hours. So the technical difficulties are obviously higher in CRRT when compared to peritoneal dialysis. So the influence on hemodynamics in peritoneal dialysis, it is little lesser. And in intermittent hemodialysis, the hemodynamical instability is more when compared to peritoneal dialysis, and CRRT. So the control over fluid removal in PD, we actually do not have control. We target it, but we may achieve or we may not achieve in peritoneal dialysis. But in CRRT and intermittent hemodialysis, we achieve more control over the fluid removal. So catheter-related issues in peritoneal dialysis, we generally see any obstruction, any leak or peritonitis. In because it's a vascular access in IHD and CRRT, it is hemorrhage, thrombosis, and dislocation. Peritoneal dialysis is available in most of our centers, and we can perform. Most of the neonatologists have also performing peritoneal dialysis. Coming to CRRT and IHD are not much available in our Indian market. We are also doing CRRTs in children, but IHDs we do not do in newborn children. So anticoagulation is not necessary. We do give a very, very minimal dose to prevent clotting. As I've already told that in intermittent hemodialysis, sometimes we may avoid it in required cases, but in CRRT, because of the very low blood flow rate, we have to have a anticoagulant. So coming to the solute removal, the clearance is more in CRRT and hemodialysis. And for rapid solute clearance, always, as we have told, intermittent hemodialysis is superior. Easy to use in neonates is definitely peritoneal dialysis, but CRRT is also we are using depending on case need. So I'm just telling you the recent usage of CRRT in 2 children. So here in this study, they have used, this is done in this case report is from St. Louis, USA. So here they have used, in 2 children, they have used CRRT for hyperammonemia. So they have used hyper CRRT, that is high dose CRRT. That is, instead of 2000 to 3000, they have used 8000 ml per meter square for ammonia clearance. That is called as high dose CRRT. And both the children had a very good favorable outcomes in these children. One was methylmalonic acidemia and one child turned out to be citrullinemia. So there is the recent advances in kidney replacement therapy is the recent study in 2021, which is published, where they have used HF20 filter, which and here one of the authors is Dr. Siddharth K. Sethi, who is also a pediatric nephrologist from India, and Dr. Rupesh Raina, and who are also part of the Indian team who have done these, we have written this paper. They have also elaborated on the use of HF20 filter. So we have 3 studies where they have used HF20, and all the 3 cases, they have seen very, very good favorable outcomes in children where they have used HF20 filter. And they have not reported a single side effect related to a single side effect related to the reaction to the membrane in any of these children. So that's a very good news and a promising results, where we are encouraged to use these filters in our units also. So thank you. If you have any questions, you can drop it in the comment box. ఏదైనా ఉందేమో చూడాలా?